Hello students, my name is Dr. Tom P. Varghese. I am an associate professor at the Conservative and Endodontics Department of Vinayaka Shankaracharya Dental College, and I will be today taking the topic on air abrasions. Okay, so let's begin with what do you mean by air abrasions, or what is the importance of an air abrasions. Air abrasions comes in minimal invasive dentistry. What do you mean by minimal invasive dentistry? We all consider ourselves as a conservative dentist. We have to conserve the maximum tooth which is vital, or maximum tooth structures which is that's why we known as an conservative dentist. So what is the problem with the traditional types of air rotors? They remove the excessive dentine and enamel. So something known as air abrasion was introduced. But air abrasion is not a new days topic or a recent advance. It was there before itself. In 1990s it was introduced, but it was not come to the market, or it was not successful. Why? Because that time the material which we used in dentistry was amalgam. So with amalgam we need an extensive tooth preparation. But nowadays things has been changed. Why new restorative materials came into role, like composites came into role, so which can adapt to the tooth structure without an extensive tooth preparations. So let's go into details of this air abrasions which is introduced. Now minimal invasive dentistry, it is an hour as the conventional extensive preparation is being challenged, and the more conservative forms of operative innovation have been recommended. Procedures that aid in the removal of carious hard tissues causing little or no damage or to the adjacent sound tooth structure has been researched. The study using an air abrasion technology of the dental application was initiated by Dr. Robert Black in 1940s and was successfully introduced in 1915 with the air dent abrasion. In spite of showing promising results, the concept did not gain popularity due to three major factors. Firstly, air abrasion was not able to prepare cavities with well-defined margins, well-defined walls and margins, and the materials during that time mostly amalgam and direct or indirect gold, which needs an extensive tooth preparation. Secondly, the introduction of the air turbine handpiece in the late 90s made conventional cavity preparation less time consuming. Thirdly, a high viscosity suction has not been developed. Evacuation of the powder was difficult. Though the basic concept of the air abrasion device has remained the same, it has been experienced a rebirth, not due to the changes in the device but due to the improvements in the bonding, restorative materials, isolation and high volume suctions. Air abrasion can be best described as a pseudo-mechanical, non-rotary method of cutting and removing dental hard tissues. The term micro-air abrasion and kinetic cavity preparation has been used synonymously to describe an air abrasion. Studies have been shown that bonding of the enamel and dentine surface prepared with an air abrasion is much better than conventional carbide burrs or acid etchings. With the introduction of flowable and nanofill composite, it is easier to restore the cavities which do not conform with the specifications of G.V. Black concepts. Another major concern regarding the powder particles has also been attributed due to the use of isolation in the form of rubber dam and high volume evacuation devices. Air abrasion also has the advantage of decreased noise and vibrations as compared to the conventional rotary instruments. Now coming to how does air abrasion works. Air abrasion for the restorative preparation removes the tooth structure using a stream of aluminum oxide particles generated from the compressed air or bottled carbon dioxide or the nitrogen gas. The abrasive particles strike the tooth with high velocity and remove small amount of the tooth structure. Effectively of the removal is related to the hardness of the tissues or the materials being removed and the operating parameters of the air device or air abrasion device used. A number of parameters such as the amount of air pressure, particle size, quality of the particles passing through the nozzle, nozzle diameter of the handpiece, angulation of the nozzle of the handpiece and distance from the object and time of exposure to the object vary the quality of the tooth removal and the depression and the depth of the penetration. Generally, air pressure ranges from 40 to 160 psi. The recommended levels at 100 psi for cutting and 80 psi for surface etching. The most common particle size are either 27 or 50 mm in diameter. The larger particles allow the clinicians to work faster but will result in comparatively large size cavity preparations than those with 27 mm particles. High particle flow rate will allow more particles to abrade the work surface faster. The speed of abrasive particles when they hit the tooth depends upon the gas pressure, nozzle diameter and particle size and the distance from the surface. Then how does it work? Typically, operating distance from a tooth range from 0.5 to 2 mm. Further, distance produced are more diffuse stream than resulting in a diminished cutting ability. A number of variations in the tip angulations and nozzle diameters are available. Small nozzle diameters can be used for the areas that are difficult to access. The various tip angulations allows easy placement and orientation of the handpiece, thus easing the strain of the operator. What are its uses or what are the applications of the air abrasions? Specific indications for the use of air abrasion includes caries removal, removal of the small existing restorations, preparation of the tooth structure for the cutting or the etching, for the placement of the composites, porcelains and ceramics, and as an adjunct to the conventional hand burr piece. Some of the situations where the air abrasion has particularly proven a boon include as removal of superficial enamel defects. These are much easier with air abrasive since they result in removal of less tooth structure than the drill. Second, air abrasion is an excellent tool for detection of the pit and fissure caries, where clinicians, radiographs and patient risk factors make the pit and fissure caries suspect. Air abrasion can be used to remove the organic debris and determine if caries is present. Use of the burrs for this procedure would remove far more sound enamel than few micrometers removed with the air abrasions. In the event of the operator not locating any carious lesion, the area can be easily be sealed using a pit and fissure sealant. If the caries is limited to the enamel, then a sealant or flowable resin-based composite can be placed. If caries penetrates into the dentine, then the preventive restoration can be used with a heavily filled resin in deep or wide area subject to the force of mastication. What are its uses? Air abrasion can also be used for the removal of pit and fissure stains on the enamel before the placement of resin-based composite restoration or porcelain veneers. Teeth where the caries is restricted only to a small section of the tooth can also be prepared using an air abrasive for conservation of the sound tooth structure. Box preparations for class 2 cavities can also be prepared. Surface preparations of affractions and abrasions. Air abrasion breaks the glaze of the highly polished surface that is not suitable for the bonding and procedure a highly textured surface that is excellent for the wet bonding techniques. So this is an image showing how these air abrasions removes a small fissure or pit and fissure caries. You can see that there is a small fissure caries there which is being removed easily with air. Fissure, it is on the mandibular tooth and the tip of the air device is placed. Removal of the caries with minimal cavity preparation is done and the cavity is restored with a preventive resin. Removal of the existing restorations. The particles of the air abrasion can be used at high pressure for removal of the old amalgam restorations, for replacing them or for the removal and repair of the composites, glass ionomers and porcelain restoration. The use of local anesthesia while working in the dentine may be avoided because of their cooling action through the high pressure air. Now that you can see that one case report, see removing the amalgam restoration. Amalgam restoration on the maxillary molars, air abrasion device is used to remove the amalgam and complete removal of the amalgam restoration is done and tooth is restored with the composite rest. Now method or the clinical use. The number of air abrasive systems are available today, such as pre-master or H-master, air braider, pre-start, pre-air, crystal mark, all of them which works on the same principle. Some like Rondoflex Cavo system works on the principle of air abrasion technology with water spray. Operational controls are either mechanical or digital. Mechanical control is the standard in most of the device, and their control of the powder flow rate, the preliminary determine of the overspace and constitutive mass of the evacuated or washed or otherwise removed is more tedious than with the digital control, which provides a consistent minimal amount of powder while maintaining the high efficiency. In selected devices, digital control also allows for the pulsated mode of operations, providing an interrupted air abrasive stream at the settings from 0.5 to 2 seconds. Air abrasion handpiece and nozzles are removed to facilitate the sterilization and have working angles ranging from 0 to 120. For precise cutting, a might be required for the preventive resin restoration. The 80% tip is more appropriate than the 45% tip, which allows the preparations are needed, as in case of cervical erosion, cutting patterns of 45-degree tip are more appropriate. For facial and lingual preparation, a 60-degree angle produces a shallower preparation and allows for the evacuation of reflected sprays. Nozzle orifice diameters range from 200 to 800 mm. Large nozzle orifices are required with a high powder flow ratio and gas pressure to maintain the cutting efficiency. Though the exposure to the aluminum oxide particles may be considered a hazard, for proper evacuation with high volume suction take care of it and can be supplemented with extra oral evacuating systems that are designed to remove the dry particles. However, caution should be used with the patient with a non-respiratory disease including asthma. Good suction and a rubber dam that extends over the nozzles, which helps to minimize the inhalation of the particles by the patient. Then operational success for the air abrasion system. Air abrasion results in intraoral mirror. Majority of the air abrasion operative procedures eat up an average of 2 to 3 mirrors per procedure, particularly when indirect vision is used. In an effort to conserve the mirrors, the dentist will have the tendency to migrate towards the direct vision, which can lead to obvious long-term deleterious effects on one's back. This mirror is designed by crystal mark dental system, can withstand the indirect blast of abrasive powders that are the part of any parcel of air abrasion dentistry. These mirrors come with gold plated for the ease of identification by the staff and the fit the standard number 5 cum socket handle. This is the image of the mouth mirror which was developed to preserve, which can be used for the air abrasion techniques. Then sand trap. These are the soft plastic spheres that split onto the office suction and have top opening through which the air abrasive system tip is introduced. This device traps the abrasive particles within the sphere from where they can be evacuated through the suction. This preventing the abrasive particles from entering the patient's oral cavity. Power plus booster. Available as an accessory to pre-start, recompresses the compressed air up to 135 psi to increase the air pressure to allow the faster cutting, thus reducing the patient chair time. Disposable air abrasion handpiece. The abrator is a single-use air abrasion handpiece that connects to your extended air line. It is the direct alternative to the traditional, expensive, self-contained air abrasion units. The abrasor comes in 3 grades. High performance for small initial lesions and cavity preparations. Medium performance for sealant, etchants, bondings and high strain applications. Light performance, sodium bicarbonate powder for removing the stains, cleaning and polishing. Super high volume evacuation system. Like a rapid vac or a union medical evacuation system is the ideal companion for all air abrasive systems. Delivering super high volume suction, these devices completely eliminate the chances of contamination of the dental operation with abrasive particles. Microwave. Mechanical vibrations of the microwave tip helps the resin to penetrate the narrow gaps. It also improves the flow of the pit and fissure sealants by increasing the contact between the sealant and tooth structure for effective restoration of the cavities prepared using the air abrasives. Does air abrasion has any limitations? Though air abrasion can be used in large number of clinical situations, there are certain limitations to its use. First, air abrasion is not an effective means of removing large amalgam restoration, especially as there is a concern for the level of mercury released when amalgam is abraded. Air abrasion of the amalgam for 1 minute releases mercury vapors 4 times in excess of the OSHA standards. Same in the true regarding the removal of the full cover restorations. Air abrasion is also not effective for removing the gross caries because it does not cut the substance that are soft and resilient. Also, the depth during the cavity preparation cannot be controlled, so it has to be accompanied with visual inspection in the regular intervals. The splattering of the powder particles with the oral cavity and or their accidental injection into the other area of concern for which the use of rubber dam isolation is a must. Additionally, patients, operation and the office staff must be equipped with protective eyewear to prevent the abrasive particles from accidentally entering the eyes. Air abrasive systems also cannot be used in conjunction with the magnification device such as loupes or dental operating microscopes, as the rebound particles could cause damage to the lens. Care must be taken when working near soft tissues due to the risk of laceration, air restriction and embolism. An inverted spray to soft tissues is not likely to cause damage, but a prolonged direct spray could potentially cause an injury. Air abrasion produces a rounded texture cover surface margins and thus is not suitable for the restorative preparations requiring definite walls and sharp, well-defined cover surface margins such as those needed for the conventional amalgam or a metal or a porcelain inlays or onlays. Though it has been claimed that air abrasion does not obviate the need for air acid conditioning of the enamel prior to the sealant placement or composite restorations, since such a studies has also been reported that a combination of air abrasion followed by acid etching has much bonding strength compared to these procedures carried individually. To conclude, the resilience of the air abrasive system with newer restorative materials has the new dimension to the minimal invasive dentistry. The mechanical bonding of the restoration to the tooth structure through the maximum preservation of healthy tooth structure negotiates the need for the conventional GV black design parameters. So, to conclude that air abrasion techniques is not a latest technique, it is an older technique, but due to the limitations in the restorative materials like that we have previously used only amalgams or direct restoration. So in that case air abrasion cannot be done. That's what it was discovered. But when the latest techniques like composites, later restorative materials like composite came into play, the air abrasion became a rebirth. They got a rebirth. So what are the major advantages of using an air abrasive techniques? To conclude, it's that air abrasion techniques is a minimal invasive techniques. It does not remove too much of the enamel or the dentin as an aerator or a conventional cavity preparation devices used. Second, but it has some more limitations. What are the limitations? Because it cannot be used for removing the amalgam restoration to widen. What will happen? You know that amalgam, if you remove the amalgam, there will be mercury contaminations, which will, while removing it with air abrasion techniques, too much contamination will be there. So it should be avoided. You can use an class 1, class 2, class 3 cavities with minimal tooth preparation needed. Then you can go for an air abrasive techniques. Thank you for listening to my presentation.